So thank you very much for this very kind introduction. So during my presentation, we will move to something completely different. We'll be talking about vessels, small vessels, which are frequently ignored in the field of neuroscience, but you will be quickly convinced that small vessels can lead to major problem in the brain. And to quickly start, so these are typical, so there is a delay. Right? So you can, as you can appreciate on this cartoon, so these are typical brain MRI of patients affected with a disease affecting these small vessels. So the main lesions, you can see these small holes, which are infarcts. And in these patients, there are multiple infarcts, small lacunes. These white matter spots, white matter lesions, these tiny microbleeds and these big hemorrhages. So these are the main lesions observed in patients affected with disease caused by affecting these small vessels within the brain. And one key feature is that all these lesions are located in the deep parts of the brain. So these diseases, so all these diseases are caused by lesions affecting either the function or the structure of these vessels running on the surface of the brain or penetrating into the brain. So just to give you a short glimpse at the problem which caused. So small vessels in the brain are responsible for 25% of ischemic stroke, the vast majority of spontaneous intracerebral hemorrhage, and it's the second cause of dementia. So these are diseases which progress, these are chronic diseases which progress many years before becoming clinically symptomatic. And one of the frequent symptoms you see is on brain MRI, you see these white spots and patients are still asymptomatic and then they become symptomatic and develop these multiple infarcts and cognitive declines. So the two major risk factors for this disease are aging and blood pressure. And there are also genetic factors, and a small proportion of these diseases are monogenic, and we consider that the vast majority is multifactorial. To briefly summarize what we can do for this patient, almost nothing. So we don't have any specific treatment. So these are frequent disease, chronic disease, very severe disease, and no treatment. And the main reason is that because we essentially do not know the mechanisms of this disease. So it's a new field. So when I was trained as a neurologist a long time ago, and I never heard about small vessel disease of the brain. It's with the routine use of brain MRI that we can recognize this disease with this very tiny infarct in the deep part of the brain, these white spots that we can recognize and identify these patients. So today I would like to address three main questions we have in this field. The first question is, what are the earliest molecular and cellular changes in the vascular wall, and what effect do these changes have on cerebral blood flow? The second question I would like to ask is the mechanisms of white matter lesions in ischemic small vessel disease of the brain. So in this film, this film is plenty of dogma, and one of these dogma, and you won't see any review on small vessel disease of the brain without seeing that the blood-brain barrier leakage is the main cause of this disease. So is it true? And the third question is that there are two forms, to be very schematic, there are two forms of SVD. There are patients with ischemia and there are patients with hemorrhagic and with hemorrhages. So what causes the difference? Why there are ischemic form of SVD and hemorrhagic form of SVD? So to address, and we'll start with the first question, to address the two first questions, we, in my lab, we use a genetic form of ischemic small vessel disease of the brain, which name is cadazine, and which we use as a genetic paradigm of ischemic SVD. And for the story, it was the first disease providing convincing evidence that with lesions in the small vessels, you get dementia. So it was a clinical proof of concept. So this genetic disease is, it's a rare disease, but not so rare, probably more frequent than the number of neurodegenerative disease. So it's one of the most frequent hereditary small vessel disease, and it includes all clinical and MRI features of sporadic SVD with these recurrent strokes, white matter lesions, and leading to cognitive decline and dementia and death of the patients. So this disease is caused by highly stereotyped mutation in a receptor, the NOTCH3 receptor, a receptor which is mainly expressed in the small vessels. So, and one key features of these mutations is to lead to the accumulation of the extracellular domain of NOTCH3 in these deposits, these gum deposits, which are located in the vessel wall. So on this picture, you can see that at the end stage of the disease, you have a massive smooth vessel cell degeneration in these small vessels. You can not barely recognize the smooth vessel cells, so the cells located in the vessel wall, they have almost completely disappeared. So one interesting thing, finding with this disease is that it's a perfect example of a continuum from a monogenic, pure monogenic disease to multifactorial small vessel disease. So in the monogenic forms, the mutations are located. So this is a cartoon, a schematic of the NOTCH3 receptor, and the mutations are located exclusively in the extracellular growth factor repeats of the extracellular domain. In the very severe forms, the mutations are essentially clustered in the N-terminus part of the receptor. And but in the general population, so these are rare mutations in the general population. But if you look, and these are cysteine mutations, so these are mutations changing the number of cysteine within an EGF repeat, which normally contains 6 cysteine residue. And in patients, you end up with an EGF repeat with only 5 or 7 cysteine. So these cysteine mutations are very easy to recognize. So in the general population, it was recently found that the frequency of these cysteine mutations was extremely high, 1 in 1,000. And these mutations are located in this part of the receptor. And it was recently shown that these mutations constitute a risk factor of small vessel disease. So perfect continuum between a pure monogenic and a multifactorial disease. So explaining the relevance of using this disease as a model to tackle some questions related to small vessel disease. So we generated a number of mouse models, and we have fortunately one mouse model which recapitulates the early stage of the human disease. So the earliest manifestation in this disease is this vascular accumulation of NOTCH3 in these deposits and some functional alteration of vessels, and then white matter lesions and modification of cerebral blood flow. So we ask the questions of what are the mechanisms of this functional alteration of the brain vessels. So as I mentioned before in the introduction, yes. So on top of the pathogenic cascade in this disease, we have an accumulation of notch of the extracellular domain of NOTCH3. And by doing immunoelectron microscopy, we discover that this accumulation occurs so in mural cells, in cells in the vessel wall, and it accumulates exclusively at the interface between the plasma membrane and the basement membrane. So, and these deposits grow to lead to these gum deposits. So these are located in at this interface between the plasma membrane and the basement membrane. So suggesting that maybe accumulation of this protein could change the composition of the extracellular matrix of these cells. So we did a mass spectrometry, and we dissected brain vessels from our mouse model, did mass spectrometry, And we identified proteins which were upregulated in the brain vessels of our mutant mice. So among these proteins, we found vitronectin, TIM3, which is a tissue inhibitor of metalloproteinase 3, and HTRA1. So HTRA1 is particularly interesting because it's the product of a gene which is mutated in an other small vessel disease of the brain. So showing that there are some common denominators between these diseases. So we validated the abnormal accumulation of these proteins into the gum deposits in mice, in mice with cadazine and in patients with cadazine. And we analyze all these three proteins and for the implication in the functional alteration of brain vessels in our mice. And we ended up by finding that it was the accumulation of TIM3 which was responsible for this functional alteration of brain vessels. And I will discuss today only the consequence and their implication in the alteration of neurovascular coupling or also functional hyperemia, which is the increase in cerebral blood flow in response to neuronal activation. So what we discovered is that so in the normal physiology, so in one-type mice, we discover this pathway in which ADAM17 cleaves HBEGF, which activates this RBB1 and RBB4 receptor, and to regulate cerebral blood flow increase in response to neuronal activation. So if you knock out ADAM17 or if you inhibit this receptor by pharmacologically, you dampen functional hyperemia. And in cadazine, in the cadazine situation, because of this non-3CD accumulation, which leads to the accumulation of TIM3, it blunts this pathway. And we use multiple approaches to confirm the causal relationship between this alteration of this pathway and functional hyperemia deficit. So this is an example. So if we perfuse a TIM3 on top of a cranial window, and if we stimulate the whisker and record the increase in cerebral blood flow, so in the wild-type situation, you should have this in response to whisker stimulation. And if you superfuse TIM3, it decreases this increase in cerebral blood flow. And it's absolutely specific of TIM3 because if you superfuse TIM1 or TIM2, nothing happens. So, and conversely, in cadazine mice, if you just reduce the amount of TIM3, you can rescue these functional hyperemia deficits. So we did a number of pharmacological and genetic experiments to demonstrate the causal relationship between the excess of TIM3 and alteration of this pathway in its implication of functional hyperemia deficits. But what causes at the vessel, at the level of the vessels, what does this impaired pathway cause? So I'm collaborating with Mark Nelson for a couple of years, and Mark is a big expert in the potassium channel, and he discovered in 2017, he discovered this electrical signaling mechanism in the capillaries, which is at the core of this functional hyperemia. So basically, when there's neuronal activity, it can release potassium, which activates this key R1 rectifier potassium channel, which hyperpolarize the endothelial cells, hyperpolarize smooth muscle cells to induce a dilation of vessels and increase of cerebral blood flow. So what we discovered is that this electrical signaling was impaired in cadazine mice, and because of this excess of TIM3. So this morning, it has been pointed that technological discoveries are important. New techniques are important to address questions. And Fabrice de Bertrand in Mark's lab has developed this very clever preparation in which he can dissect a tiny brain artery with the capillaries attached. He pressurizes this capillary, and he can mimic this electrical signaling ex vivo. So if you apply potassium here, close to the capillaries, you can induce a dilation of the arteries, and this dilation is impaired in the SVD mouse model. And we could confirm in vivo by a two-photon microscope. And when you apply K close to the capillary, you can increase the diameter of the arteries and increase cerebral blood flow in the wild type mouse, but in the cadazine mice, it's decreased. So to sum up this first part, so what we discovered is that the accumulation of natrium cause early deficit in cerebral blood flow regulation through a potassium channelopathy-like dysfunction. So I mentioned and I discussed what is the cause of functional hyperemia deficits, but we also showed that this excess of TIM3 affect the activity of this KV1 channel, which are very important for smooth muscle cells to dilate, and which is the mechanism by which in cadazine there is an alteration of autoregulation of cerebral blood flow. So we can rescue these deficits by passive immunization against NOTCH3, and we can also acutely rescue these deficits by increasing the activity of KR 2.1. So to summarize this first part, what we discovered is that changes of the extracellular matrix occur very early in the disease process, but it cripples cerebral blood flow regulatory mechanisms through a channelopathy-like dysfunction, and this can be rescued by either by chronic or acute pharmacological intervention. So meaning but these are a functional alteration in the function of neural cells. So now I would like to discuss briefly the mechanisms of white matter lesion in ischemic SVD, which is like a blueprint of this disease, this white spot that you can see on the MRI before the appearance of clinical symptoms. And the dogma here is that it's caused by blood-brain barrier. So is there any evidence of blood-brain barrier dysfunction in this disease? So again, we took the cadazine model as the cadazine disease as a paradigm to address this question. So we first characterized what are exactly the nature of these white matter lesions, and we use a technique of electron microscopy with quick freezing and at very high pressure to avoid these many artifacts which are caused by standard processing of the samples. So what we found is that basically at the early stage of the disease, it's a problem of myelin. It's a problem of myelin with a split, the myelin is split. So these are the electron microscope from cadazine mice with an enlargement of the inner tongue. So the axon is here, vesiculation of the inner tongue. So there is at the very beginning, we have myelin damage. And if you quantify the number of myelinated axons, it's at the very beginning unchanged. So if you calculate the G ratio, it shows that there is a myelin thinning. So at the very beginning of a disease, it's a problem of myelin and not a reduction in the number of axons. So, and we could confirm, and we did this in collaboration with Cyril Bouvon and Rospin. So we did ex vivo brain MRI, and just to look at fractional anisotropy, which is a very good marker of white matter lesions, and not surprisingly, but to confirm that these alterations were diffuse, because with electron microscopy, you just look at a very small piece of a tissue, small region into the brain of the mouse. So in our cadazine mice, we found a reduction in fractional anisotropy and in every white matter bundles. So as I said, the dogma in the field is that the blood-brain barrier is leaky because pericyte degenerate, allowing proteins which are in the blood to enter into the brain and become toxic and cause degeneration of oligodendrocytes, affect myelin, and cause degeneration of neurons. So this is the dogma. But when we analyze the blood-brain barrier of our mice, and we had very nice control, positive control, we could not find any evidence of leakage of tracers that we injected into these mice, small tracers, big tracers. And when we analyze in detail the coverage of these pericytes and the number of pericytes, so which are key cells to maintain the integrity of blood-brain barrier, we could not find any alterations. So what we did is that we again turned to the use of brain MRI, and again in collaboration with Cyril. And Cyril we did a microscopic MRI. I mean, we did a very, very long acquisition, and we combined diffusion MRI with relaxometry, the quantitative relaxometry, and we were close to 80 micrometer isometry. And these were 3 days acquisition, and we and Cyril combined this with a multi-compartment model to extract a number of information regarding axon, myelins, through water, and it did also to extract a quantitative measure of myelin. So what we found is that we found something very consistent with what we found with electron microscopy. I mean, we have a slight reduction in the quantity of myelin in the white matter bundles, and no significant change in the number of axons. But the big surprise came from the quantification of extracellular free water, which we found increased in our cadazine mice. And there was a very significant increase in extracellular free water. So we went back to our electron microscopy pictures, and we realized that we completely missed this phenotype of enlarged extracellular space. So to summarize this second part, the blood-brain barrier, there's no, if we define a leakage of blood-brain barrier by the ability of exogenous tracers to enter into the brain, it's not affected either in patients and in mice. But we have an increased extracellular free water, and coming back to the data in patients, it's highly consistent. So our data are suggestive that at the very beginning to explain these white matter lesions, it's a modification of permeability to water. It's a problem of permeability to water. So the third question is why some patients develop bleedings and others develops ischemia, which is a big question. What caused the difference? So to address this question, we use a second model, again, a genetic model, but which we use a genetic paradigm of hemorrhagic SVD. So in this model, so it's a disease we present in patients, in human, and the disease is caused by heterozygous mutation in COL4A1 or COL4A2. So these two chains assemble to form a collagen type 4, and which is a major component of vascular basement membrane. So patients develop bleeding at every age with variable expressivity, incomplete penetrance, and fortunately, we have 2 mouse models which faithfully recapitulate the full spectrum of a human disease. So when you look at the brain of these mice which develop hemorrhages, so the hemorrhage develop around small, deep penetrating arteries, and this is associated with a degeneration and a loss of smooth muscle cells which are within the vessel wall, and which you can see by this immunohistochemistry and also by electron microscopy. But I have to make a short stop on the organization of the vascular network. You all know the artery, the capillary, the vein, and what we discovered is that in between there is a zone, there is a transition zone So this stain the neural cells which are around these vessels. And as you can appreciate, so the shape of the cells around arteries is completely different from the shape of these neural cells around this transition zone between the artery and the capillary. And and you can here recognize a typical pericytes with this bump analog shape. So when we looked at the various compartments, vascular compartment in our COL4A1 mutant mice, what we realized is that in the artery, in the mutant mice, there were loss of smooth muscle cells. But if you look at the transition zone, so these branches which comes from the arteries, we had the opposite phenotype with a higher number of cells expressing more contractile proteins. So to confirm that it was not simply an immunohistochemistry results, we did some functional analysis. Again, technologies is important. So again, in collaboration with the Nelson Lab, Nick who is a very talented postdoc, developed this very clever preparation, which is a pressurized retina preparation. So the beauty of this preparation is that you have the retina, which is pressurized here, and you can analyze the whole vascular network. And because of very stereotype angioarchitecture and organization of vascular network in the retina, you can say just by positioning the microscope here, you can tell this is an artery here, it's a transition zone. And what we found, Julien so moved with he traveled to the US with the mice, and by analyzing the contractility and the tone of this transition zone in COL4A1 mutant mice, we found that the transition zone was had more tone and was more contractile. So, and to cut a long story short, we found that this hypermuscularization of this transition zone was caused by an increased activity of NOTCH3. So we could generate a COL4A1 mutant mice with an attenuation of this hypermuscularization of transition zone, but still the same holes and the same degeneration of smooth muscle cells. And despite this, we could almost prevent the appearance of the intracerebral hemorrhage. So we have in this COL4A1 modified mice, we still have smooth muscle cell degeneration, but we revert the phenotype at the level of this transition zone, and we could prevent the appearance of intracerebral hemorrhage. So this cartoon illustrates what happens and what is the mechanism. And we could demonstrate by analyzing tissues from sporadic patients with sporadic intracerebral hemorrhage, but the vessel bleed because you have a loss of smooth muscle cell at the level of our artery, and in the transition zone, you have an excessive muscularization, which increases the tone, increases the pressure at this level, and favor the rupture. So what is the difference between an hemorrhagic SVD like this and an ischemic SVD like CATASIL? Because in CATASIL, we barely see, it's extremely rare to see patients with intracerebral hemorrhage. So we analyze the arteries and the transition zone in the CATASIL mice, and what we found, and these are pictures in the retina, and the retina is a very beautiful preparation to look at the central nervous system vasculature. We found that at the level of arteries, we have smooth muscle cell loss and degeneration, and at the level of transition zone, we have also a loss of neural cells. So the opposite that we see in the COL4A1 mutant mice. So by collaborating with mathematicians, and we did some computational modeling. So again, we use the vascular network in the retina. So as the vessel, go deeper into the network, the pressure inside the vessel decreases. And this is the modelization in the wild type situation where the pressure decreases as you go downstream in the vascular network. So if you do this computational modeling in the hemorrhagic SVD, you see that the decrease in the perfusion pressure along this vascular network is lesser. So pressure is abnormally up. If you do the same modeling in an ischemic small vessel disease, it's the opposite. So what we do believe at this stage is that we have other data also showing that the loss of smooth vessel cells at the level of arteries, it's a common denominator in both ischemic and hemorrhagic SVD. But the difference is at the level of a transition zone. So in an hemorrhagic SVD, you have an hypermuscularization, and in an ischemic small vessel disease, you have a loss of neural cells in this transition zone. So we speculate that because of this combination of these two and the loss of neural cells at this level, it decreases the tone and the pressure, leading to ischemia, especially in the deep part of the brain, because of this organization and this terminal and vascular network. So I would like to thank people in my lab, and so I'm located at the Institute of Psychiatry and Neuroscience in Paris, and people in my lab did the work. So Nicolas, who is working on the calcium model, Florian also working on the mechanisms of notch CD accumulation. I did not show the data, and previous postdoc worked, Julien, on the COL4A1 on the hemorrhagic SVD, Monara and Rikesh worked on the white matter, mechanisms of white matter lesions, and our current collaborator and sponsors. And I would like also to thank our many collaborators in the past who have made possible all this work. So thank you.